Are you there?
Yes.
Okay.
A 25-year-old primary gravid woman is admitted in labor with 39 weeks of gestation. The cervix is 6 centimeter dilated 100%. Cervix is 6 centimeter dilated 100% effaced. The presenting part is not palpable. Fetal heart rate is 140 per minute. The estimated fetal weight is 3.2 kg. Which of the following is the most appropriate next step?
Ready?
Yes.
So it's ultrasound. Ultrasound of the pelvis will allow the clinician to determine the fetus position when not presenting fetal part can be felt at the cervical opening. Fetal malpresentation occurs when any portion of the fetus besides the occiput, whatever, presents at the cervical os. Malpresentation prevents the head from properly engaging in the pelvis for descent. For example, the excess amniotic fluid in polyhydramnios can prevent any body part from presenting at the cervical os until rupture of membranes occurs. A serious complication that can occur in the fetal malpresentation is umbilical cord prolapse. Because the lack of occiput engagement at the cervical os, the cord can protrude to the cervix following rupture of membranes before the baby descends in the pelvic opening. Further contractions then cause the cord compression and fetal hypoxia. Given the high risk associated with vaginal deliveries in the setting of fetal malpresentation, delivery is usually completed via elective C-section once confirmed by ultrasound. Cord prolapse, however, is a obstetric emergency requiring immediate C-section. It's not oxytocin augmentation causes uterine contraction and is frequently used to induce labor. However, this patient is already in active labor, and oxytocin augmentation will increase the risk of the risk for rupture of membranes with cord collapse given the potential malpresentation. And it's not C-section. It's generally indicated in fetal malpresentation. However, the best next step in management is to determine the fetal position with ultrasound rather than moving directly to C-section. Prior to confirmation of the fetal life, vaginal delivery may still be an option. Okay, next.
An asymptomatic 52-year-old newly gravid woman comes to the physician for a routine health maintenance examination. Her last visit Her last visit to a physician was 4 years ago. Mens occur at regular 30 to 32 days interval. There is no bleeding between the menses. She smoked one pack of cigarette daily but quit 5 years ago. She drinks 1 to 2 glasses of wine per week, in addition to pap smear mammography and cholesterol testing. In addition to pap smear mammography and cholesterol testing, which of the following is most appropriate at the time?
Is it bone or is it colonoscopy?
I'm not sure.
Do you do colonoscopy even if the person don't have? I don't know. Okay, ready?
Okay.
Okay. So it's it's colonoscopy. Um, what is it? USPTS, whatever, recommends routine screening for colorectal cancer in adults between 50 to 75. Colorectal cancer is the second most common cause of cancer death in the US. Early detection and treatment have been shown to reduce mortality. A variety of screening techniques are used, including colonoscopy every 10 years, test of the occult blood for and fecal immunochemical testing, FOTBT or something, performed manually. Okay. Or stool DNA with fecal immunochemical testing every 1 to 3 years. Colonoscopy carries the benefit that any visualized colonic polyps can be immediately removed and sent to for histologic evaluation, making it a diagnostic and therapeutic modality 50 to 75. It's not bone densitometry is recommended by USPT as routine screening in women over 65. And in those at risk for osteoporosis, osteoporosis risk can be assessed using the standardized calculation tools such as the fracture risk assessment tool. So it's 65. Okay, okay. Next.
A 42-year-old woman comes to the physician because of 1 year history of vaginal bleeding for 2 to 5 days every 2 weeks. 1 year history of vaginal bleeding 2 to 5 days for every 2 weeks. The flow varies from light to heavy with passage of clots. Means previously occurred at regular 25 to 29 days of interval lasted for 7 days with heavy flow. She has no history of serious illness, take no medication. She is sexually active with one male partner. They use condom inconsistently. Her mother died of colon cancer. Her maternal grandmother died of breast cancer. She is 5 feet 4 inch. She is 5 feet 4 inch tall, 77 kg, BMI 29 kg per meter square. Temperature is 36. Pulse is 90. Temperature. Respiration is 12. Blood pressure 100 by 60. Uterus is normal sized. The ovaries cannot be the ovaries cannot be palpated. The remainder of the examination showed no abnormality. Test of the stool for occult blood is negative. An endometrial biopsy specimen shows grade 1 adenocarcinoma with atypical endometrial hyperplasia. Which of the following is the most appropriate next step?
Hmm. Ready?
Yes,
So
grade
we do
1.
hysterectomy, irregular or unpredictable bleeding, or bleeding not associated with usual premenstrual signs and symptoms like bloating, breast fullness, uterine cramps, should prompt investigation for pathologic causes. Endometrial cancer is a cause of abnormal uterine bleeding, as are cervical endometrial polyps, adenomyosis, inflammation and infection of genital tract, coagulopathy, ovulatory dysfunction, and endocrine dysfunction like thyroid disorders, prolactin, androgen. Iatrogenic and idiopathic causes of abnormal uterine bleeding also occur. In women of reproductive age, pregnancy must also be ruled out as a cause of abnormal uterine bleeding. When endometrial hyperplasia or carcinoma is a concern, endometrial biopsy is needed. Risk factors for endometrial carcinoma include obesity, prolonged estrogen use, early menarche, late menopause, nulliparity, advanced age. Family history. With biopsy and imaging, the stage of endometrial cancer is detected and follows TNM staging, so tumor nodes metastasis. If the disease is confined to the uterus, as in this patient, then surgical excision is the first line therapy. This is achieved through a hysterectomy with bilateral symphyngophorectomy. It's not C and D. Endometrial ablation is a potential treatment for menorrhagia in a premenopausal woman, as menorrhagia may also be caused by endometrial hyperplasia or cancer. All women undergoing endometrial ablation should have an endometrial biopsy first to exclude um, the presence of these conditions, but it's for premenopausal women. Dilation and curettage is useful in treating heavy and abnormal uterine bleeding that does not respond to less invasive interventions, as well as for removing the fetal tissue or retained products or constellation. While it could debulk a portion of the endometrial tumor, it will not remove microscopic disease. It will not be an appropriate treatment for cancer. So you do endometrial ablation, then you do, I guess, yeah, endometrial ablation. If that don't work, okay.
Endometrial ablation for in premenopausal.
Premenopause, dilation and curettage for usually abortion. I never heard dilation and curettage for endometrial, usually for abortion. Yeah,
Yes.
okay. Next.
30-year-old woman, gravida 3, para 2, 10 weeks of gestation, had fever, minimal vaginal bleeding, severe pelvic pain for 36 hours. She says that she says that it is an unwanted pregnancy. 4 months ago, she was treated with oral antibiotics for pelvic. 4 months ago, she was treated with oral antibiotic for pelvic infection. Temperature is 104. Temperature is 104. Examination shows foul-smelling vaginal discharge and small laceration of the cervix. The uterus is extremely tender and consistent in size with 10 weeks of gestation. Leukocyte count is 18,000 and 18,000 with left shift. Which of the following is the most likely diagnosis?
Vaginal bleeding, foul smelling. Oh, I'm between PID and septic abortion. Foul smelling discharge, small laceration on the extremely tender. Okay, let's go with that one. Ready?
Yes,
Okay, so aseptic abortion. Spontaneous abortion describes the non-induced loss of a fetus prior to 20 weeks gestation and is subdivided into the following: threatened, inevitable, incomplete, complete, mixed, and septic. Non-induced. Okay. In septic abortion, infection occurs within the uterine cavity, resulting in inflammation, and the immune response leads to loss of pregnancy. Hmm. Symptoms of septic abortion include pelvic pain, foul smelling discharge, vaginal bleeding, fever, and chills. Examination generally discloses uterine tenderness, cervical inflammation, and purulent cervical discharge. Treatment includes antibiotic and evacuation of the uterine contents. Wait, septic abortion means that I thought septic abortion was like they tried to remove the baby and then they left some product of conception there
that
and that got affected.
that is not retained product of the conception.
That's not septic abortion.
No, may not be.
Oh, okay. And then it's not PID. What is PID? It's not pelvic inflammatory disease result from ascending infection into the pelvis via the cervix and uterus. It presents acutely with fever, nausea, abdominal pelvic pain, at nasal and cervical tenderness, and abdominal cervical discharge. What's the difference? It's the same thing.
In the PID, there is no written like uh, what can I say? They are consistent with the size. The uterus has still presence of product, 10 weeks of size. You got my point.
No.
The uterus is extremely tender, uh, consistent with the size of 10 weeks of gestation. So uterus has still the presence of product of the conception.
O-
Like
Okay.
in abortion, like something is giving thread. So apart from like missed abortion, that means product of conception is gone. In here there is product and there is sepsis also. So that's how it is septic abortion.
There is abortion and there is sepsis also. Okay.
In the
Okay.
PID there is like infection, but there is uh, no product of conception as far I guess.
Oh, okay. Okay. So you're never gonna see a PID pregnant woman.
No, not
Okay.
really.
Okay.
I may be wrong. I guessed. Okay. I'm trying to making things sense. Okay.
Make it make
Leave it.
sense. Okay.
A 30, a 32-year-old primary gravid woman, 10 weeks of gestation. 32-year-old primary gravid woman, 10 weeks of gestation comes for first prenatal visit. She has history of 2 to 3 seizures yearly, but she has had 2 seizures over the past. She has had 2 seizures over the past 2 weeks. Medication include phenytoin. Examination shows a uterus consistent with size of 10 weeks of gestation. Her serum phenytoin is 5. Which of the following is the most appropriate next step in the management?
Oh, Jesus.
Phenytoin can not be given in pregnancy, isn't it?
Yeah, but then what you gonna give? The only other option are carbamazepine and
Listen,
valproic acid. Both of them
valproic
are,
acid. Sorry,
but I think both of them are teratogens, right? Carbamazepine and valproic. They are both teratogens, right?
phenytoin
Like pen.
also causes gamma hyperplasia.
Yeah, that's what I'm saying. All of the three are teratogens. So I mean, you are you gonna switch one to the other? I don't know.
Okay, let's see.
But increasing the care, yeah, that's the only thing that makes sense. Many physiologic changes occur during pregnancy that affect drug distribution and metabolism. The physiologic increase in blood volume during pregnancy results in an increased volume of distribution for certain medications. At the same time, plasma protein concentration is decreased, resulting in more free serum medication than in the pre-pregnancy stage. Additionally, the rate of hepatic metabolism and renal clearance are also typically increased. Therefore, titration of antiepileptic drugs is commonly performed through the analysis and trending of unbound drug concentrations in the serum. While phenytoin and other antiepileptic drugs do carry a risk for congenital malformation, fetal hydantoin syndrome, teratogenesis more often occurs in the first 8 weeks of conception. Failing to provide adequate seizure control puts the mother and fetus at risk for pregnancy complications, including preeclampsia, stillbirth, fetal growth restriction, prematurity. In this patient, altered pharmacodynamics have led to decreased efficacy of phenytoin dosage. An increase in the dosage of current medication is the most appropriate next step to prevent seizures. You want me to read us another one?
No,
Wait, 13. Yeah, it's fine. Next.
I'm losing my focus. What can I do?
Oh, you want to get coffee or something?
No, no, no. Like,
What do you,
not coffee thing. Like, actually,
I don't understand.
I am losing out of my focus from the USMLE. So what should I do?
Like I don't understand what you mean. Like right now, like you're
No, no, not right now. Not right now. As a whole.
when you say you are losing your focus, you mean like you are forgetting what you study, or like you don't have
Like
motivation
I
to.
am feeling like I should give up.
How you gonna feel you need to give all your exam is in like 3 days?
No, no. I extend my exam.
No, what?
Yes, I extend for three. I extend for the 3 months.
No, Oma, you lying. When did
True.
you?
If if my exam in within 2 days, so is it possible to read with you in that fashion?
No, I mean, we just spoke yesterday, and I was telling you like, okay, you need to do your amboss immediately because you have like 2 3 days to go.
No, no.
No,
Is it possible to do ambush within 2 to 3
I
days?
don't
Is
know.
it
Some people already they say they do it the last week
last?
before the exam. They say that oh, during that last week
Don't
before my.
fall on that trap. Don't fall on that trap. Like they what they told, like they do in the last week and these and that, they actually do earlier.
Oh.
And people who are giving NBMEs, they actually give earlier. Just free 120 and these type of exam they
Mm-hmm.
are giving it at the last moment. But the
At the
rest,
last minute.
because if you give NBME in the last week, how can you solve that NBME? Like there is a huge study.
Mm-hmm.
So
That's true.
if
That's
you
true.
give NBME and just go as a casual manner, you are not able to perform in the exam
Oh
because
my
you will.
God, I was
y-
counting on you. I was like, oh my God, if Omar passes, I know I'm gonna pass because I'm gonna be like, I studied with him. I mean, like, yeah, I was, I was telling my husband, I was like, I'm gonna see if Omar passes, I'm gonna be so excited because I'm pretty sure I'm gonna pass. Oh my Lord, oh, now I'm nervous now myself. Oh Lord,
I am very bad. Like I am losing my focus. After
no,
giving
you
that,
cannot.
NBME, I actually losing my focus from everything.
No, but I mean, it was like you said you only took like two, and it's I
Sorry.
mean, it's not. You said you only took like two MBMEs, so it's not like there is a lot more. Even if you failed two and you passed all the other ones, it's not. But yeah, I didn't want to tell you, hey, you should push your exam date because you shouldn't go take the because I did the same thing. I went and take the exam the first time. I didn't pass. I took five MBMEs and I failed all of them. And I still went and sat for the exam my
Yes,
first time.
that doesn't work in the exam.
I wa- I
You are
it was
not able to, like if you don't able to pass in the NBMS in home,
yeah.
so
Yeah.
you
That
are
was
not.
like my mistake.
Yes,
And I was like, it was horrible. Like I was like, what was I thinking? You cannot even pass one MBMB and you go and sit for it. That's like the most stupidest thing. So I wanted to tell you, don't go if you don't pass at least one, don't go and sit. But since you were like, okay, I'm gonna take it. I'm just gonna get over with. I was like, okay, hey. And also, I can see you doing questions and you get the questions right. So that's why I'm like, okay, maybe you just I don't know, worry when you're taking the exam, but you actually know the answers. So but 3 months is going to be what, August?
yes.
You don't think it's going to be too close to the date to the when the thing opens?
Do you think that I am able to apply this year? Nothing is secured.
Why not? You cannot
I don't.
apply this year.
I don't have anything. I don't have any visa. I don't have any research. I don't have nothing.
Oh, you do. I mean, I know a lot of people that have
So
matched without.
it does like uh,
Unless you want a competitive, unless okay, that's different. Because if you're looking for like a like neurosurgery kind of thing, okay, yeah, I guess yeah, maybe you need research. Okay, I don't know.
you
Maybe I'll
you
push
need
my
you need research and you need something else like
the
your CV should be good for getting chance. I don't know about you as because you are a US citizen. So for you it may be easier because you come from like where Houston, like
no,
Houston Medical.
I know a lot of international that match, but it depends on this on what residency you want. Because the ones I know that match without research and all that, they weren't applying for like surgery and things like that. They were applying for like emergency medicine, family medicine, things that are not like super
Okay.
competitive, But if you're looking for like a competitive residency, then yeah, I guess
Like
yeah.
if you want to get the internal medicine, then what are the requirements?
I don't think you need research. A lot of research is more for like surgery and things like that. Internal medicine, good recommendation letters from internal medicine doctors. Like I think that's like yeah, I
Compulsory?
think
Yes.
yeah, that's like the most. Internal medicine, family medicine is not like that, you know. But once you start going into OBGYN and
You want to
sur-
do?
no, I don't want to do OBGYN.
Okay.
I mean, if I listen, if I at this point I'm desperate. Oh my, whatever they take me, I'll go.
Okay.
Okay, whatever. Yeah, I'm desperate. I already felt twice, so at this point I cannot be like, oh, I want to do this. I want to whatever they take me, I'll go. If I could choose, then yeah, I would choose something I like. I would do like general surgery, but at this point, yeah, whatever they take me, I'll go. I'll go. I don't,
Okay.
I don't mind. But yeah, then if you push your exam, then now you need to yeah, you need the extra motivation now. Because I don't know.
I
You need
don't
to
know
find your
myself.
no, you need to find your motivation. Now you don't have you need to find the motivation somehow. I don't know. So
I
what do you want to what's your plan for the next 3 months? You just want to do CMS?
no. I will do UWorld. I will do CMS, and I
You
will
want
try to do Amboss also if I can buy.
how much is that? Did you I never checked on that. I never
It
checked
is
that.
$139 maybe, and
For 1 month?
for 3 months as far as
You cannot do 1 month because I feel like with 1 month I should be able to just get the
one
the
month
main
is
questions.
$100.
Oh. I feel like I just because we just need those to do those questions and review them, the ethics question and just review them. Do we need like a lot of I don't have money for that. Do we need like a lot of months? I don't know. I think I'll just get 1 month.
Okay,
Yeah.
let's see what happens.
Let's see what happens. Oh my god, I can't believe I was so excited. And I was so confused because you were still doing questions with me. I was like, when is Omar gonna be like, hey, I need to focus, I need to rest. My exam is in 2 days. But I didn't want to say anything. I was like, okay, maybe he just want to do questions until the last day, the day before. Oh jeez. Okay. Okay.
Okay, okay, I was reading the question. 27-year-old primary gravid at 30 weeks of gestation comes to the physician because of 3-week history of pain in his pain in his arms and numbness in her hands that awaken her from sleep. She says that in her hands she feels as though she has been sleeping on them. Her pregnancy has been otherwise complicated. Examination show mild weakness of the thumb, abduction, Thumb abduction bilaterally sensation is decreased in the pinprick in the index finger of the right. Which of the following is the most likely diagnosis? Thumb abduction bilateral.
Sensation is decreased. Pink, pink. Let's see. Oh, jeez. Quick sympathetic.
Think simply.
Yeah. It's like think simply. Okay. Ready.
Because in the Reddit, people are saying these words quite a lot.
But it's true. It's true. Like now
We
that I'm
we we
solving.
we are actually start thinking in such a manner, then we lost the track.
Mm-hmm. But now that I started doing CMS with you, I realize that yeah, I don't know about the real, but I think the CMS is just really think simply. Don't
Yes,
try to yeah.
CMS is making us learn to think simply.
Yeah.
In the UL, there is a complex question, but in here, there is not
Mm-hmm.
that complex question. Okay.
Mm-hmm. Carpal tunnel syndrome results from compression of the median nerve within the carpal tunnel of the wrist. The carpal tunnel is located anterior to the carpal bones and is bound to the flexor retinaculum. Oh, bound by the flexor retinaculum. Flexor tendons of the fingers course through the tunnel along with the median nerve. The space is rigid and does not generally permit compression. Thus, any inflammatory, traumatic, space-filling lesion may result in carpal tunnel syndrome. Patients generally present with pain and paresthesia in the median nerve, dermatomal distribution, along with weakness involving the muscles of the thinner eminence. Okay. Reduced grip strength and weakness of thumb abduction may result. Symptoms are generally worse at night. Pregnancy is a non-risk factor for carpal tunnel syndrome, and it's hypothesized that the fluid retention expands the synovium within the tunnel, leading to nerve compression. Okay, so fluid compresses the nerve. Carpal tunnel syndrome is frequently associated with hypothyroidism, rheumatoid arthritis, acromegaly, amyloidosis, ganglion cyst, obesity, acute trauma to the wrist with impingement, and chronic remodeling and scar formation following a wrist injury. Management includes treating the underlying cause, splinting the wrist, and decompressive surgery to relieve pressure and prevent irreversible median nerve palsy. I like those short questions.
A 14-year-old girl is brought to the physician because of painful episodes of menstrual cramping. Painful episodes of menstrual cramping over the past 5 months. Has the pain has caused her to miss several days of school monthly. Menarche was at age 12 years. Her last menstrual period was 5 days ago. 5 days ago. Examination shows no abnormal. Which of the following is the most likely cause of her pain?
Hmm.
Painful.
Ready?
One sec. Okay.
Is prostaglandin production. Primary dysmenorrhea or painful menstruation is a common cause of cyclic pelvic pain in healthy patients and occurs in the absence of secondary causes such as endometriosis and adenomyosis, cervical stenosis, or uterine fibroids. Symptoms often begin during adolescence and commonly interfere with quality of life and with essential activities such as school and work. Patients describe cramping lower abdominal and pelvic pain that begins several days prior to the onset of menses, which persists for several days along with fatigue, nausea, vomiting, presyncopal symptoms, and headache. Endometrial sloughing is accompanied by the production of prostaglandins, which stimulates painful uterine contractions. Patients are typically treated with NSAID drug that inhibits COX enzyme, thereby limiting prostaglandin synthesis, and with oral OCPs. It's not endometriosis is a common cause of pelvic and abdominal pain that is caused by hormonally responsive ectopic uterine endometrial cells. Other common features of endometriosis will be dyspareunia, dyschezia, infertility. While endometriosis should be excluded in this patient, it is less likely than primary dysmenorrhea. Okay, next.
A 32-year-old woman, a 32-year-old woman, gravida 1 para 134 weeks of gestation, is admitted to the hospital in labor. Pregnancy has been complicated by blurred vision and 2.3 kg weight gain over the past week. Her last routine prenatal visit 1 month ago showed no abnormality. Her temperature is 37 degrees Celsius, pulse 80 per minute, respiration 20 per minute, blood pressure 150 over 110. Examination shows retinal arteriolar spasm and pedal edema. Labs show hemoglobin 12.5, leukocyte 8,000, platelet count 2 lakh, serum creatine 1.2, urine protein is 2 plus. The patient's fetus is at greatest risk of which of the following obstetric complications? Patient's fetus is greatest risk. Fetus.
Ready?
Yes.
Okay. So it's fetal growth restriction. These patient findings of hypertension, proteinuria, and organ dysfunction occurring after 20 weeks of gestation is consistent with preeclampsia. Preeclampsia is caused by um, abnormality of the placental spiral arteries and post-trophoblastic inflammation, leading to placental hypoperfusion and the subsequent production of vasoactive hormone that cause generalized endothelial dysfunction, hypercoagulability, and vasospasm. It usually presents in the second or third trimester after 20 weeks of gestation. Preeclampsia may lead to uteroplacental insufficiency that puts the fetus at risk of fetal growth restriction. If untreated, preeclampsia can progress to eclampsia characterized by seizures, which can have profound adverse effects, including maternal stroke, cardiac arrest, renal failure, or maternal or fetal death. Preeclampsia is treated with antihypertensive eclampsia prophylaxis with magnesium sulfate and delivery of the fetus and placenta. It's not, what's that compared? Oh, pulmonary hyperplasia is commonly observed as a component of Potter sequence as a result of uh, oligohydramnios. Okay, got it. Next.
52-year-old postmenopausal woman comes to the physician for a health maintenance examination. She does not smoke cigarettes, drink alcohol, diet low in fat. She received ERPR replacement therapy for vasomotor symptoms. For vasomotor symptom, her blood pressure is 130 by 76. Her blood pressure is 130 by 76. The patient is at greatest risk of which of the following type of cancer?
Oh, Jesus. It's not long.
ERPR therapy.
Yeah.
She receives ERPR, estrogen progesterone replacement
If it
therapy.
was just estrogen, we'll have an idea, but she's also having progesterone.
Progesterone.
So, ah, I don't know. I know it's not that. Okay, ready?
Yes.
Probably endometrial or ovarian. Or is it breast? Ah, breast. Exogenous estrogen raises the risk for breast and endometrial cancer. Okay. However, the concurrent use of progestin negates the effects of unopposed estrogen, drastically decreasing the risk for development of endometrial cancer. Breast cancer can express estrogen or progesterone receptors, which will result in increased growth in the presence of exogenous hormone supplementation. Oh, got it. Okay. Other risk factors for the development of breast cancer include family history of breast cancer, BRCA mutation, early menarche, late menopause, nulliparity, obesity, African American. It most commonly presents with abnormal, potentially palpable breast lump with or without associated skin or nipple retraction. The USPS recommends a screening mammogram every 1 to 2 years for patients over 40. If a patient presents with a palpable lump, a diagnostic mammogram should be initially performed, followed by ultrasound of the concerning region if the patient is over uh, 30. For patients under 30, ultrasound should be primarily be performed for evaluation, as the mammogram is limited because of the breast tissue. If there are concerning findings for a breast malignancy, a percutaneous biopsy is needed. Is not cervical, okay, yeah. Cervical cancer can be asymptomatic or present with postcoital bleeding. Risk factors include HPV, smoking, immunosuppression. Estrogen is not a risk factor. Endometrial cancer typically presents with postmenopausal uterine bleeding with risk factors including prolonged unopposed estrogen, such as early menarche, late menopause, PCOS, exogenous estrogen therapy, nulliparity, obesity. The risk of the endometrial cancer is decreased relative to breast cancer with the current administration. Okay. Ovarian cancer typically presents with indolently with abdominal distension and weight loss in a postmenopausal woman. These factors include family history of ovarian cancer, genetic, the BRCA mutation, increased age, smoking, nulliparity, PCOS. Estrogen progenitor hormone therapy does not play a role in the development of ovarian cancer. Got it.
Okay, can we take a 1 minute break? I'm coming.
Yeah. Yeah.
Okay. Yes. 27-year-old primary gravid woman, 37 weeks of gestation, admitted to the hospital in labor after uncomplicated pregnancy. After uncomplicated pregnancy, fetal heart tones are reactive spontaneous rupture of the membrane occurs with moderate blood-stained fluid, followed by a deep persistent fetal bradycardia. The uterus is soft and non-tender. Cervix is 3 cm dilated. Cervix is 3 cm dilated. There is vertex presentation. Which of the following is the most likely diagnosis?
Placenta previa. Passa previa. Ready?
Yes.
So it is vasa previa. Vasa previa is a condition in which the fetal blood vessels overlie the cervical os. It is commonly associated with placenta previa, the implantation of the placenta partially or completely over the cervical os. Given the position of the fetal blood vessels, they are at an increased risk for rupture with onset of labor. The ruptured membranes can result in damage to the fetal blood vessels, which can cause significant fetal hemorrhage and potential fetal exsanguination in them. Classically presents with bloody amniotic fluid immediately after rupture of membrane, spontaneous or after amniotomy, with rapid onset of severe fetal distress marked by late decelerations and persistent bradycardia. Risk factors for vasoprevia include in vitro fertilization, multiple gestation pregnancies. Diagnosis is typically made prior to labor with routine ultrasound, and management consists of elective C-section at 35 to 36 weeks gestation. Is not placenta previa progresses presents with painless vaginal bleeding during the third trimester caused by a placenta that partially or completely overrides the cervical os. It is a risk factor for vasa previa, but less likely to cause significant fetal hemorrhage without vasa previa. Okay.
Okay.
Mm-hmm.
3 months after an uncomplicated vaginal delivery of newborn at term, 24-year-old woman Gravida 2 Para 2 comes to the physician because of 1 month history of pain with sexual intercourse. 1 month history of pain with sexual intercourse. She breastfeeds her infant who recently was treated for thrush. She awakens to feed him every 3 hours during the night. Her mens have not resumed. Vital signs are within normal limit. Physical examination shows no abnormality. Pelvic examination shows erythematous vagina with no tissue. Cervix is closed. Uterus is normal in size. Cervix is closed. Uterus is normal in size. Which of the following is the most appropriate next step in the matters?
Hmm. Ready?
Yes.
Use for a lubricant. Recommendation to use of a lubricant. Breastfeeding women are at increased risk for atrophic vaginitis because of the antagonist effect of prolactin on estrogen production. Okay. In women who are not breastfeeding, atrophic vaginitis only occurs as postmenopausal change. Hyperestrogenemia
Hypo.
leads to hypoestrogenemia leads to atrophic vulvovaginal changes and can present with symptoms of irritation, itching, dryness, dyspareunia. Exam shows atrophy of the labia, decreased secretion in mucosal erythema and friability. Treatment includes topical estrogen and the use of lubricant during sexual intercourse. Women who also require contraception can also be treated with estrogen containing oral contraceptive. Okay. Okay. Next.
21-year-old primary gravid woman, 41 weeks of gestation, is admitted to the hospital in labor. Pregnancy had been uncomplicated. Contraction every 3 minutes. Cervix is 100% if it's 4 centimeter dilated. The vertex is at 1 plus station. The membranes rupture, yielding moderately thick meconium stained fluid. Moderately thick meconium stained fluid. The fetal heart rate has a baseline of 130 per minute variable deceleration, lasting 45 seconds and decreasing to 60 minutes. Which of the following is the most appropriate next step?
Mm, what was variable deceleration? Bill
Well, chop variable deceleration. C for cord
core,
compression.
core compression. Mm, 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 Forceps delivery. Okay, ready?
Mm, yes.
So it's amnioinfusion. Variable deceleration following rupture of membranes are suggestive of umbilical cord compression. Umbilical cord compression. Okay. Amnioinfusion is the process of instilling fluid into the amniotic cavity. Amnioinfusion is useful for alleviating umbilical cord compression by increasing the volume of fluid in the amniotic cavity. Although amnioinfusion is the most correct response of the options provided here, evidence for the benefit of amnioinfusion towards improving outcomes related to meconiums.
Pelvic examination show fixed tender retroverted uterus, a nodularity of the uterosacral ligament, and tender admixture bilaterally. And there is 5 centimeter tender cystic adnexal mass. A pregnancy test is negative. For which of the for each patient with abdominal or pelvic pain, select the most likely diagnosis. Is it endometriosis?
I think so.
Okay.
That's what I think. Okay. Mm, The answer is endometriosis. Presence of ectopic endometrial tissue outside the uterus may occur close to the uterus, such as in the cervix, within the fallopian tube, in the broad ligament on the ovary. The tissue may also be distant, such as in the visceral peritoneal surface of the intestines or the rectum, within the peritoneal cavity or within the thorax. Endometrial tissue remains hormonally sensitive, and symptoms often fluctuate on a cyclic monthly basis as the tissue progresses through the histologic phases of proliferative and secretory endometrium. The sloughs during menses, then sloughs during menses, sorry. Symptoms include chronic dysmenorrhea, dyspareunia, dyschezia, infertility. Physical exam may include tenderness to palpation of the affected structures or visualization of endometrial implant on the cervix or vaginal wall. Diagnosis on endometriosis is definitely made through laparoscopy to visualize and sample endometrial implants. Okay.
A 27-year-old woman, gravida 3 para 3, had been gravida 3 para 3 had the sudden onset severe sharp pain in the right lower quadrant of the abdomen, pain in the right shoulder, lightheadedness, nausea, and rectal pressure 6 hours ago. She uses a diaphragm for contraception, and her last menstrual period was 24 days ago. Her blood pressure is 120 by 70, pulse is 80 per minute, no orthostatic change. There is a moderate tenderness of the right lower quadrant of the abdomen without guarding or rebound tenderness. Blood, uh, blood sounds are active. Chaldosynthesis is 15 ml non-clotting serosanguinous fluid with a hematocrit 5%. A pregnancy test is negative.
Hmm. Hmm. Mm. And then pressure, you say pressure in the rectum. Okay. This inflammatory. Ah, that makes sense. Okay.
Alright.
Ready?
Okay.
Okay. The answer is, did I pass it? No. Oh, rupture corpus luteum cyst was completely out. The corpus luteum develops from mature follicle, rather after the egg has ovulated during the menstrual cycle. Some cases, the corpus luteum forms a cyst, which can potentially rupture. A ruptured corpus luteum cyst classically presents with unilateral pelvic or lower abdominal pain that is sudden and severe, most commonly after sexual intercourse or other physical activity. Physical exam will disclose a tender abdomen with a potentially unilateral adnexal mass. Was there an adnexal mass here? No. Palpated on pelvic exam. Pelvic ultrasound will show complex cystic mass or free fluid in the pelvis, which may include hemorrhagic components, hemoperitoneum. Cholescentesis, rarely performed, typically produce serosanguinous fluid as the corpus luteum is highly vascular. It is typically managed with observation and supportive care. Okay, and it's not, what did I fix it? Appendicitis classically presents with acute worsening periumbilical pain that migrates to the right lower quadrant along with fever, nausea, and anorexia. She doesn't have fever. Okay, I guess she doesn't have fever, nausea, and anorexia. And it's not, what was my other one? Uh, Inflammatory bowel disease includes ulcerative and chronic. Classically presents with chronic crampy abdominal pain or bloody diarrhea. She doesn't have bloody diarrhea. What was the key here then?
Corpus luteal cyst.
Yeah. Mm, because right lower quadrant, I guess they mean in one of the ovaries. I guess it was the cholescentesis.
Maybe cholescentesis there is 15 ml non-clotting serosanguinous blood. But the cholescentesis is actually rarely performed. Typically, you got it.
Okay, so that means if it's performed, that's a clue for corpus luteum. That's why the
Maybe
okay. And then the fact that it travels to the right shoulder and all that is like
it looks like the it is referred pen and looks doesn't look like appendicitis. It looks like what can I say? Show in the referred pain in the shoulder like cholecystitis.
cholecystitis. Yeah,
Yes.
yeah.
So appendicitis pain does not go to this area.
Even if because appendicitis when it explodes, when there's the abscess and it explodes and all that, doesn't it does still doesn't go
No,
from there. Okay.
may not be.
Okay. Next.
Appendicitis pain may radiate to the right iliac region, from
Right.
umbilicus to the right iliac fossa.
Okay. Okay.
Okay. A previously healthy 37-year-old A previously healthy 37-year-old woman comes to the physician because of 5-month history of bloody nipple issues from her left breast. From her left breast, examination of the breast show no palpable masses or skin retraction. Blood can be expressed from ductal element. Blood can be expressed from ductal element of the Nipple of the left breast mammography showed no abnormality. Which of the following is the most likely diagnosis? Uh, okay.
Ready? Intraductal papilloma is the most common cause of unilateral bloody nipple discharge, which may reflect malignant pathology if present in the setting of palpable breast mass. Intraductal papilloma are benign tumors originating from the walls of the lactiferous ducts and proliferate into the ductal lumen. The papilloma is usually too small to be palpated externally. Intraductal papilloma can be solitary or multiple. Initial diagnosis is typically made by ultra, ultrasound and cord needle biopsy. A small portion of intraductal papilloma contain regions of atypical cells and ductal carcinoma in situ. Removal of the papilloma can be performed with surgical excision or microdocectomy, excision of the lactiferous duct, which facilitates more detailed histopathologic analysis. It's not infiltrating ductal carcinoma is the most common form of breast cancer and often presents as a painless lump, although many patients are asymptomatic. Mammography may show microcalcification and or infiltrative mass. Diagnosis is made by cord needle biopsy and excisional biopsy. Okay. Stoppages disease of the breast present with eczema-like patches on the nipple is associated with underlying ductal carcinoma, and insidious or invasive carcinoma of the breast. Okay.
A 22-year-old primary gravid woman that in 9 weeks of gestation has had ruptured membrane for 5 hours without contraction. Her prenatal course was uncomplicated. Cervix is 80% effects, 2 centimeter dilated. Fetal position is right occipito-posterior. The fetal heart rate pattern is shown. Which of the following is most likely explanation?
Mhm.
Isn't it
Mm.
sinusoidal pattern?
Is it right? Is this right?
Looks
Uh,
like.
so that's caused by what?
Baby sleeping.
The sinusoidal?
Maybe
Mm.
because heart rate is normal.
Yeah, that's true. Okay, I guess sleeping. Okay. Oh, okay. Ah, I'm not. I don't know why I'm not. Fetal post right occiput posterior. Okay, fine. I'll go with sleeping. Okay. It is sleep rate. Yeah, fetal sleep state. Um, Minimal variability, which is defined as less than 6 beats per minute. Variation from the baseline heart rate, as seen in this case, can be caused by fetal sleep state, hypoxia, opioids, and magnesium. When caused by hypoxia, the fetal heart rate tracing will also typically show either tachycardia or bradycardia, depending on the severity of the hypoxia, along with late or variable deceleration. Okay. This can indicate uteroplacental insufficiency or umbilical cord compression. As this patient shows no signs of distress, the fetal heart rate is normal, and there has been no administration of opioid or magnesium. The minimal variability seen is most likely caused by fetal sleep. It's not chorioamniocentate amnionitis, bacterial infection, fetal membranes. It commonly occurs in premature or prolonged rupture of membranes. Maternal fever and leukocytosis are characteristic, and the uterus may be tended to palpation. Fetal heart rate will show probably tachycardia. Makes sense. And it's not occiput posterior position, is a form of fetal malposition. in which the occiput is posterior rather than anterior and posterior. Okay. It increases the risk for fetal arrest of descent caused by inability of the fetus to travel to the pelvic opening. However, it does not cause a decrease in fetal heart rate variability unless accompanied by complications during labor. Okay.
A 42-year-old woman, gravida 5 para 5, comes to the physician requesting advice regarding contraception. Means occur at 28 days interval. Her last menstrual period was 3 days ago. She has hypertension treated with beta blocking agent. She she often forgets to take it. At the age of 21 years, she was treated for chlamydia trachomatis infection. During her second pregnancy, during her second pregnancy, a smear was reported. A smear was reported as a low-grade squamous intraepithelial lesions after delivery. For a follow-up, Pap smear showed no abnormality. Since that time, she has had no abnormal Pap smear. She is sexually active, monogamous relationship, physical examination failed. She desires most effective pregnancy that remember. Um, she will easily remember to use. Which of the following is most appropriate recommendation for regarding contraception? That's all uh, she desires most effective contraception you will easily remember to use. Okay,
Ready?
yes.
Okay, so it's IUD. Intrauterine device. IUD is a long-acting reversible contraception option that does not require active compliance on the part of the patient. Both copper and levonorgestrel IUD are available. The copper IUD provides contraceptive method without the use of hormone. Copper is spermicidal and inhibits sperm motility and the chromosomal reaction necessary for fertilization, as well as it induces local inflammatory changes of the endometrium and increases cervical mucus production, further decreasing the chance of sperm passage or embryonic implantation on the endometrium. Potential complications include increased menstrual flow and pain during menses. Hormonal IUDs also cause cervical mucus thickening and induce glandular atrophy of the endometrium, preventing implantation. IUD are a reliable form of contraception with failure rates as low as 1%. Depending on the type, they may be kept in place for up to 10 years. Oh, that's nice. D, not D, depot medroxyprogesterone, which is injected every 14 weeks, approximately 3 months, are both forms of hormonal contraception. Neither will be optimal in a patient with concern for medication compliance. Additionally, though not applicable in this case, hormonal contraceptives are contraindicated in patients with a history of thromboembolic disorders, liver dysfunction, and breast malignancy with estrogen or progesterone receptor positivity. But he doesn't, okay, she doesn't have any of it. Okay, next.
Okay, 2 days after a cesarean delivery for fetal distress, a 27-year-old woman a 27-year-old woman has a temperature of 100 degrees Fahrenheit. She had a 8-hour labor complicated by mild meconium stain, amniotic fluid membranes ruptured 2 hours after admission. Breath sounds are decreased at both lung bases. Abdominal examination show mild tenderness below the umbilicus, and a well-healing lesion. There is moderate amount of lochia with no odor. Examination of the lower extremities show edema and no tenderness. Her hemoglobin is 10.8. Leukocyte count is 14,000. Platelet is 1,89,000. Urine catheter specimen is negative. Which of the following is most likely diagnosis?
Ready?
Wait, what am I thinking? Okay,
Mm. Oh, never mind. Oh wow.
I
The
thought
next one.
endometritis. What have you
Me
thought?
too. Endometritis too. That's what I picked. I was like, okay, this is an easy question. That's not. Did not see that one coming. Atelectasis refers to the partial or complete collapse or incomplete expansion of pulmonary parenchyma. There are multiple types of atelectasis, including obstructive, passive, compressive, cicatricial, and adhesive. It is most common in patients who are gravid, immobile, or in a post-surgical state who are unable to produce adequate tidal volume to expand the lungs. Oh, in gravid patients or patients who have just undergone vaginal delivery, increased intra-abdominal pressure caused by the gravid uterus pushes on the diaphragm and intrathoracic cavity, thus decreasing the ability of the lungs to expand. Okay. Physical exam will show diminished respiratory efforts, often with reduced breath sounds at the lung bases, corresponding to the regions of non-aerated collapsed lung and inadequate diaphragmatic excursion. Pain control, incentive spirometry, and respiratory therapy with lung expansion maneuver are key initial steps in management. What does that have to do with the fever? Like, wait, I'm like confused.
In this question, I think that there is the clue is breath sound is decreased at the lung base. But atelectasis happens, collapse happens in the upper region, isn't it?
No, I mean here it makes sense because of the uterus is compressing the bottom region of the lung. So, but my thing is like they're asking for the diagnosis of she has fever and then meconium stain and rupture. So I'm like, even if this is a clue, the breath sounds, but it doesn't have it anyway. I'm just okay. Let's just read the other. Let's just yeah. This question
Look
is
at the
good.
endometriosis first.
Endometritis
Endometritis.
is an acute typical polymicrobial infection. Yeah, because they said that the uterus is tender or something.
Yes.
Okay, anyway. Typical polymicrobial infection of the uterine endometrium. Patients typically present with fever, tenderness of the uterine fundus, mucopurulent discharge. Okay, she doesn't have that. Risk factors for the development of the endometritis includes prolonged rupture of membrane greater than 18 hours. Okay, she didn't have greater than it. She only had like uh, 8 hours or something, like 8, 10 hours. And then, but they said that the uterus is was the uterus painful? Not really. Okay, not really. They didn't say the uterus was, but the leukocyte count was high. How is
Yes.
it at metastasis and the leukocyte count is high? Anyway, whatever, it's fine.
Sorry.
And how is it at telectasis and the leukocyte count? That's what I'm saying. It doesn't that the leukocyte count is high. How? What does that have
With
to do with
within
metastasis?
8 hours,
What? So what does that mean?
like very rapid rise of the leukocyte count.
It's not
Okay, okay.
septic.
Atelectasis. Okay. The according to the rule of the W, this can be do you know about the rule of the W?
Mm-mm.
Wind, water, womb, and wonderware. Wind is atelectasis. Like in post-operative, if you just leave this question into the surgery part, like first post-operative day, the most common infection is atelectasis because the patient lies and is unable to patient cannot do the breathing exercise. That's why atelectasis can happen.
Mm-hmm.
And the third post-operative day is water, and water means urinary tract infection can occur, or pneumonia can happen with the fever. And wind, water, womb, like DVT, and wonderwear, like in the 10th postoperative day there is abscess. I have read somewhere the W
Mm-hmm.
rule. You have heard, I think so.
No, wind, water. You said wind, water, then what?
Wind, water, womb,
Wo-
womb, and wonderwear. Okay, I'm
wo-
seeing from the mnemonic. Okay. The 5W mnemonic: wind, water, wound, walking, sorry, and wonder drugs.
Can you
If you,
send that to me?
yes, it is in the AI. Okay, I'm sending you the link. This is the post-operative complication. If somebody comes to you, okay, you got it?
Where did you send it to? Teams?
Yes.
Wind, water. No. Okay, water. Yeah, the postoperative complication related to the uterus. Related to the uterus. Okay. Okay.
It is related to every surgery.
To every surgery. Okay.
Yes. Like in the first postoperative day, atelectasis can happen. In the
Mm-hmm.
second or third postoperative, UTI pneumonia can happen. And in the Kaplan surgery book, it is written the
Okay.
5W.
Okay. Got it.
Multiple
Mhm.
resources makes people bad.
Yeah, I no, I'm not gonna do it because when I went to medical school, that's what happened, and that's why it was so hard for me because
Yes,
everybody kept saying, "Use this book, use this book, use this
yes.
book," and
And finally, what happens? We don't go through any books, and we don't
exactly,
know. We don't have any concept from any
yeah,
books.
yeah. The basic, if I meet somebody that has to go to medicals, I'm gonna tell just get your first aid. That's all you need. Just get your first
Yes,
aid book. That's all.
just try to cram all the thing from the first.
Yes, first aid, and if you want to practice questions, do your word. That's
Yes,
it. Don't kill yourself. There's so many books there. It's just it was ridiculous.
there is so many books, and I don't know. Uh, the teachers makes us study from here and there and from
That's-
everywhere.
For me, I had
I
teachers that had
I I,
published it.
I haven't learned. I haven't learned good at. I was not good at anatomy
Mm-hmm. Me too.
because
Me
because
too.
because what happens in there, they are talking about viscera, they are talking about bones, but as it has no clinical correlation, so we don't
Mm-hmm.
remember that.
Mm-hmm.
And now it has no use. Whatever you have read, this has no
Mm-hmm.
use.
Mm-hmm.
So
That's true.
that's
And we had teachers that had published their own book.
A group of investigators conducts a study to evaluate the association between the serum homocysteine level and the risk of MI. They conclude that high baseline they conclude that high baseline plasma homocysteine level is associated with increased risk of MI and report a risk ratio of 1.08 and p-value is 0.01. Which of the following is the most accurate statement? Which of the following is the most accurate statement about the results of the study? Okay,
Jesus. Oh,
p-value
maybe.
is clinically significant, isn't it?
Yeah. Risk ratio. Oh, I don't know. Okay.
Okay.
Next.
High plasma CRP, high plasma CRP is believed to be associated with increased risk of acute coronary syndrome. A group of investigators is planning a study that would evaluate that association, taking into account a set of potential confounders. Which of the following is the best statement of null hypothesis for the study? High CRP level carries the increased risk of ACS. High CRP level is related to the occurrence of acute coronary syndrome.
Okay.
Okay,
Okay.
you are
So the first answer is B and the second answer is C. Wait,
okay.
what is
I'm
that?
reading the explanation.
Okay.
A clear explanation of the null hypothesis is essential before conducting any study. The null hypothesis states that there is no association between the exposure of the interest. There is no association between the exposure of the interest and the outcome. For example, if a study is conducted to assess the risk of MI in patients taking aspirin versus in patients not taking aspirin, the null hypothesis would be there is no association between the aspirin treatment and the risk of myocardial infarction. Unlike the null hypothesis that denies any association, the alternative hypothesis states that the exposure is in some way related to the outcome. The alternate hypothesis can specify whether the exposure increases or decreases the likelihood of the outcome one way hypothesis, or it can state that there is an association without specifying its direction two-way hypothesis. After data is collected, statistical analysis is then performed. Based on the study of the statistical analysis, we either reject or fail to reject the null hypothesis for the purpose of the USMLE board exam. When asked to interpret null hypothesis, you will typically be provided with the p-value or confidence interval. A simplified interpretation of the p-value is that it represents the probability that the null hypothesis is true. For example, if the investigator in the aspirin study report a p-value is 0.01, that this means There is 1% probability there is no association between this aspirin and the risk of myocardial infarction. A more precise definition of the p-value is that it represents the probability of the obtaining this result or more extreme result if the null hypothesis were true. In order to determine whether to reject or fail to reject the null hypothesis, compare the p-value to the preset alpha. See the description of the alpha error in the statistical power section. Most investigators believe that an alpha level 0.055% is an acceptable threshold for statistical significance. Assume that an alpha level 0.05 unless otherwise stated. In other words, the p-value is less than 0.05 and there is less than 5% probability of the null hypothesis holds true. We therefore reject the null hypothesis and accept appropriate alternative hypothesis. Remember, however, that even a very low p-value indicates there is some probability that the null hypothesis is true. The relationship of the p and the confidence interval is described later. Okay. Can you explain
Oh Lord. I,
like how you pick? I don't I don't want to know from the explanation, just what you thought, because this works for me. That's why I asked. I know it is very pressurized for you, but like your explanation helps me. That's why I remember. That's why I remember your words. You got my point. What I'm not trying to make you impress. Uh, what I feel, I just ask you. Like in my medical school, what I try to do, I try to make people study. Like I study whole night, try to explain the people, and then they, you are very astonished. I got failed in the exam,
ah,
and uh, uh, it happened. It happens in multiple items. Like we go to give the item with the three-person. The person whom I made read, they got passed, I got failed.
oh my God. That's the worst.
I am like that, and I
Oh,
am and I am not regretting that. Even if one day what happened, I am not performing good one item, I just sit up and told my teacher that I will try to I will study again and I will give the item again. Okay,
mhm.
so I'm like that, so it is not a problem.
Okay, but this one, the two make sense, right? Null hypothesis means that there is no association between exposure and an outcome. This one makes the number two. So the null hypothesis means that there is no association at all.
Association, yes.
Yeah, so that one, that's just the definition of null hypothesis, no association. So if you read the other ones, there is this one says, oh, this one increases the risk of, that's not true. This one is related to, that's not true. There is no association. Acute correct can be predicted by no. This
So
one
the word
causes
null hypothesis, and we will find the word no association.
no association, just mean no association.
Okay.
For this one, is that they are explaining that the definition of p-value means that there is, so if the p-value here was 0.002, that means there is 2% probability that there is no association. And again, we just said that no association means null hypothesis. So there is 2% probability that the null hypothesis is true.
Okay.
Does it make sense? Or
Yes.
no? Okay, makes
Yes.
okay, makes